Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio, and happy to be with you on this Thursday morning. Doc Hawk is with me, our Medical Director of Infection Prevention and Control. We'll also be visiting today with Shannon Schrader, who's the head and helps run our infusion clinic for monoclonal antibody therapy. We're going to say that correctly today because I've been saying bamlanivimab. I have been corrected. It is truly bamlanivimab. We're just going to call it Bamlan for short. So we're going to talk to Shannon in just a minute. But first, Hawk.
Yeah.
A little better news today.
A little better news, yeah. Certainly for our hospitalizations here at the health system, it's a lot better than it was a few days ago. We only have 89 active acute infections in the hospital right now.
For us to say only, that's a heck of a lot.
I know.
But it's so much better than 102.
Yeah, we are happy. I mean, that's 20 more beds of these acute patients that aren't here, so that's good. We still have 68 other recovering patients, so that's still a large percentage of those people that shouldn't be here that are still here in that recovery period. But of those 89 people with the acute infections, over half of those are in the ICU with 46, and then a large proportion of those are on the ventilator at 28 as well. Hays is doing okay. You know, they haven't gone up. We did see them fairly high. They went down a little bit. They have 37 active patients, but 25 of those are acute, and then 12 are recovering. So hopefully their numbers are going to be going down as well. But I think we're optimistic. We know that infection curve was still pretty steep if you look around the Kansas City area since October 26th or so, and only recently did it start going down. We don't know if that's a consequence of less testing or if that's truly less cases. And we know that the hospitalizations will lag behind that by about 10 to 14 days. So hopefully we can keep pushing those acute infections down.
Here's what we're going to hope. We're going to hope that the curve has flattened because it is going down, both for the number of people we have admitted early, although the total number is still like 158, so that's still really high if you put the recovering in the acutes. But the acute patients are the ones that really give us a barometer of how things are going on in the community at any one time. And to be down from 102 to 89, we'll take that.
Yeah.
I think the other question is going to be, though, what happens after the Thanksgiving holiday? What happens after all the travel, and where will we be? I don't think we know yet.
No.
I suspect that the numbers are down a little because that would have suggested what was going on 2 weeks ago, which would have been right in front of Thanksgiving.
Yeah.
And if that's the case, I'm going to suspect that some of that is some of the masking that has happened. I do think people are doing a better job about that. I think even inside restaurants are doing a little better job about that. And I think that's a really important point because I think if folks can do a better job, we can bend the curve.
Yeah.
We've done it before, we can do it again, and maybe we are doing it.
Yeah, and maybe masking at home if you did get together, maybe it was some of those gatherings that you were masking as well. So, you know, again, we're still optimistic. Hopefully we can keep decreasing the amount of acute inpatient hospitalizations as much as possible.
Okay, let me hear you say Bamlan.
I always thought it was bamlanivimab.
Okay, so
not Lou, but
we're told it's bamlanivimab. Bamlu.
No, la.
Bamlanivimab.
La. Yeah.
Bamlanivimab. Okay, bamlanivimab.
It's
or Bamlan.
M, N, and then M. So bamlanivimab.
I think it's just easier to say Bamlan. What do you think?
Bam is fine, too.
Okay, there you go. All right, let's see if, first of all, there are any questions from reporters.
Yes, hi. This is John Shorman from the Star. We're now just a few days away, potentially a couple weeks away from just the very early vaccination efforts starting among medical workers, healthcare workers. I am curious, what is your sense of how prevalent vaccine hesitancy is within the healthcare community itself? And how will acceptance of the vaccine among the healthcare industry shape public attitudes toward the vaccine?
Well, let me take the last one first because I think it's important. I think that if the healthcare industry is reluctant to get the vaccine, it's going to send a very difficult message. And once that happens, I think it's going to be a lot harder to get people behind it. So I'm hopeful that the healthcare industry, and especially the frontline healthcare workers, are not that reluctant to do it. Here's my sense of it in talking to a lot of us at this level. You know, we're pretty comfortable. We have mandatory influenza vaccination. We have to have our MMR. We have to have all of our shots up to date here. So we're pretty used to the vaccination. And I think we're going to do that. And I think most people here are very much looking forward to getting the vaccine. We want to see the data.
Yeah.
Because, Dana, we've not really seen the full set of data. We've
No.
only heard the snippets that they want you to hear. So we need to see the full set of data. And we are told that before we're going to get the actual shipments of the vaccine, we will see the full set of data, meaning about the side effects and the efficacy and all that you would see in a published paper. And I think that'll be important because healthcare workers tend to be people who want to look at the science side of this. And I think you'll see that. But here's my guess. My guess is the data is as good as we think it is. And I believe that in part because of what we're seeing around some of the signals from the vaccine and from the companies and from the FDA and from the CDC. So I'm going to venture a guess and say the data really is as good as they say it is. And if that's true, I think healthcare workers are going to be overwhelmingly positive about getting the vaccine.
Yeah, I think that's okay to be reluctant, but I want to put that into context. That is a reluctance before seeing the actual data that you just talked about. So certainly a lot of the healthcare workers want to see that data, and it will be transparent and visible. And we know that the EUA or the approval is not going to happen unless it is safe and does show efficacy as well. So I think it's okay, again, for the general population as well to be reluctant in the context, though, that you're going to do your due diligence and either read the articles that come out in the journals, because a lot of that coronavirus journals and articles are free now to the public, but also do your due diligence in looking at the CDC website, your local health department website, even a lot of the mass media that have been covering the science aspect of coronavirus. If you can do your due diligence and try to get all that information, then hopefully that will reduce your reluctance a lot. But just saying, I'm reluctant, I'm not going to take it because I don't believe in it, that's not the right way to go about it. But wanting to look at the data, at the published studies, is the right way to go about it. And it will be out there for you to see, for the healthcare workers to see, for the general public to see. And we have confidence in our FDA and the NIH that they are not going to make approval or EUA unless it does show, number one, safety, but also efficacy.
And I'll make this promise to you, John, and you'll see it here on this program. When it's my turn to get the shot, when I'm up in terms of the rank, I'm going to do it right here. I want you to see it. I want everybody to see it because I believe in what we're trying to do around that. And just as we got our flu shot right here, we're going to get our vaccinations for SARS-CoV-2 right here. I think it's really important to send a message for leaders to be able to step in and show the folks that they're not afraid to get that shot. And I think that we do that, and that's part of being a leader, and I think we need to be able to do that and show to our teams here that we believe that it's safe, and we have every confidence that it's safe. So that's my promise to you and to all of our listeners today. Any other questions? Other questions from any other?
Hey, good morning, guys. It's Taylor, Channel 41.
You bet.
Question about an update on ICU versus, for lack of a better term, regular patients. But we talked a lot this morning about how many ICU beds are available versus just beds available and that kind of thing. Can you give us an update on, as far as COVID-19 goes, what an ICU patient looks like versus a patient who is in the hospital for COVID-19 but is not an ICU patient? Or is it, obviously the severity of their symptoms are different, but what marks the difference in those two patients?
You bet. The overwhelming difference is their respiratory status. So there are other things. You can see some cardiac effects that will make you be in the ICU, and we've had a number of those. You can see some neurological changes that have you be in the ICU because you may become disoriented and you're not safe to yourself or others. But the overwhelming majority of patients in the ICU have breathing problems. They're either on mechanical ventilation because their lungs can't sustain their own life with their own lungs. They need help to breathe. Or they're on such high amounts of oxygen it needs to be delivered in an ICU setting, or they're tired, and that means they're tired, their breathing has been so labored they can't rest, and they're on the borderline of having to go on to life support. That's the overwhelming majority of patients who are in the ICU, and that's what marks the differential. And what we would say is that's an ICU patient. Then the acute care floors, which is everyone else, they tend to have similar problems, but just to a lesser degree, and don't need constant monitoring. Think about the ICU as Harry Potter on steroids, right? Constant vigilance. because you have ICU nurses operating at a 1-to-1 level, one nurse to one patient, or 2-to-1. And that's why lives can be saved, is because you have that ratio of critical care nursing, and then you, at least here, we have an ICU physician up in the ICUs all the time, and that allows us to be watching these patients very carefully. One of the things that we know from coronavirus, or really any other level of ICU illness, is the more that you stretch the ICU resources, and especially I think the ICU nursing staff or the respiratory therapy staff, when you start asking them to take care of more and more patients, they can't offer the same kind of constant vigilance, and little things go awry. And it's kind of like a football game, right? If you make little mistakes, suddenly the team starts having mistakes and you can't advance the ball and things don't go as well. In the ICU, it's very much a team sport, and if you can't have constant vigilance, little things go awry. When little things go awry, patients don't do as well, and then you lose the game. And I'm not trying to compare life and death to football, but I'm trying to help people understand why it's so important that we don't want to say, well, we'll just put, an ICU nurse can take care of 4 patients, or an ICU doctor can take care of 30 patients. Because what happens when you do that is you can't pay attention to the moment-to-moment changes of critical illness, and things change constantly. And it's the constant vigilance which allows you to steer things back into the right direction. And if you're not able to do that, things go pretty far out of line before you're able to offer some sort of corrective measures, and by then more damage has occurred. And so it's really important that we try not to overwhelm the ICU, we try not to overwhelm the teams up there. But the number one marker of disease in the ICU from SARS-CoV-2 is clearly respiratory damage.
Yeah, absolutely. I have nothing to add. That's why they go to the ICU. They will have other problems, such as you mentioned, heart or kidney or infections, but that is a minority, and the majority is that respiratory status.
And a lot of them will have all of the above. So,
yeah.
Yep. Okay. Other questions? All right, not hearing any. I think we're going to talk to Shannon Schrader in just a moment. But before we do that, we've talked before on this program about monoclonal antibody therapy. Today, we'd like to start our conversation a little bit differently by introducing you to our patient number 13. That is the 13th patient who's gotten BAMLab in our facility. This is Paul's story.
I am so grateful for something like this. I'm susceptible to a lot of things. I have no immune system, I have liver problems, and also diabetes. With all those things, I felt like if I did have COVID, it was going to be critical. If it happens, I wanted to find out as soon as possible. I've experienced them all right now. Terrible headache, tightness in my chest. I felt like my heart was having trouble beating properly, and what else was there? The smell is gone. From what I understand, it will help smooth out the rocky road to come yet, and that this has given me some hope that I won't be one of those that are on the news in the respirator. People gotta wear masks, people gotta stay distanced. This whole political issue over masks is crazy. It's about helping people, not necessarily yourself. Because by wearing a mask, somewhere I came across somebody that maybe didn't, and now I'm here.
I think you're here with us now. Thank you for joining us today. Paul is a perfect example of patients who meet the criteria for BAMLab. We could see he was hooked up to an IV. Walk us through the procedure for patients like Paul.
Yeah, so we saw Paul yesterday, really nice gentleman, but there's a great process in place to screen these patients and get them seen quickly. So as soon as a set of positive results comes through our swab clinic, there's a group of nurses working every day to vet through those patients and see which ones qualify for treatment. They're immediately called and notified and fully informed about the treatment and considered in the process, and we try to get them that same day or the next day. once they do arrive, the process is really pretty straightforward. An IV is placed. As you see, he's got an IV in there. We do check their vital signs. The BandLam runs over 1 hour, and then we observe the patient for 1 hour afterwards, check their vital signs, and send them on their way.
So I believe we've received 60 doses so far, BandLam, and Paul's number 13. He certainly looks like he doesn't feel very well. He looks like a patient who's got COVID-19. He also seems hopeful. Have the first dozen been as upbeat as Paul? And have you seen anybody call back and say, gosh, I feel a lot better?
You know, they have been really upbeat. A lot of these patients, when they come in, they're wondering, what number am I? Am I number 2, number 3? And they're excited to hear that, this treatment's available for them. I'm sure it's disheartening to get that news that you're positive for COVID, but if on that same phone call you hear, but hey, we've got this treatment available, that you qualify for, would you like to come in and get it? And those patients are saying yes, they're all wanting to come in. We did have a patient, one of our first ones, that called back afterwards just to, express her appreciation for us getting her in so quickly.
Good deal. Have you talked to anybody afterwards that says they felt better from it?
I have not specifically. I think they usually go to their primary care doctor after that, but hopefully they all are.
It's interesting. I know when I talked to one investigator with this therapy at another place one time, he was telling me it wasn't so hard to tell who got the drug and who got the placebo, because the folks getting the drug felt a lot better, and they felt a lot better pretty quickly. So hopefully that's going to be the thing, and that's going to keep on going. So what kind of reactions have people had with this?
We have not seen any reactions yet in the now 15 that we've infused. So what we tell the patients to reward for would be sort of allergic reaction, itching, hives, throat swelling, things like that. We haven't seen any. I believe the studies on the medication, we're seeing very low rates of that. And if anything were to occur, we're trained in reaction protocols with all other different antibody medications that we do give and are prepared if something were to happen.
Shannon, are the patients given alongside the other infusion patients, or is this a different area for the COVID-19 patients who are getting infused?
Yeah, currently we are keeping them separate from our patients. We're lucky enough to have some private rooms in our infusion room separate from our infusion bays. So we're actually keeping them completely separate by having them arrive in their car. They're not obviously allowed to bring any visitors with them. They do call and register from the car, so they don't come in through the front lobby. We have a back entrance that we bring them through. They go directly to that private room to be treated, and then are taken back out through that private entrance back to their car. So they're not coming in contact with any of the patients in our building currently.
Yeah, I think that makes such great sense, because we don't want to have anybody feel or have to be worried about that. How many of the infusions have we done so far?
We have done 15, but the demand is definitely getting greater. So we originally received 60 vials, but in the last week or so, we have received a lot more vials. So as the positive tests are increasing, we're hoping that we can start to get more of these patients in that qualify. There's definitely criteria the patients do have to meet. So the demand will depend on what types of patients we're going through.
All right. Well, that is great news. What are your staff doing when they're not doing this drug?
We're a pretty busy clinic. We've got 14 bays in those four private rooms. And last month, I think we had over 1,100 appointments. So we give about 90 different medications, all different sorts of things, from antibiotics and iron, other biologics, migraine treatments, just fluids, really anything.
Yeah, that is impressive. I have a lot of my patients out seeing you guys, so I know what a great operation and how much they appreciate that. So that is really important. I have a lot of folks out there getting IVIG post-transplant and things like that, and some of my CF patients. So you guys do a great job. And it's really interesting that we are trying to expand and create a space where we can fit in more patients, because I think we'll need that even after we get past COVID-19. I think there's a video of a converted infusion room that will be just for our COVID-19 patients, which is awesome. Again, I think it's really important that the patients who are coming out otherwise know that that they're going to be safe, whether they're there for COVID-19 or whether they're for one of their standard infusions. So you've already mentioned how you're keeping your patients safe and apart. That sounds awesome. Any other thoughts that you want to leave us with?
Yeah, well, actually, that video, I think they took that yesterday, but in the last 24 hours, that's gone a huge transformation. That's actually an old was a physical therapy gym that we have at our location in the back of our building, where there's another entrance that leads right into that room. And so against that back wall, we now have curtains up. We've got 3 infusion chairs. We've got IV pumps. We're hoping by Monday or Tuesday of next week to be able to run 8 or 9 patients a day, where right now we're only able to do about 3.
You know, that is awesome, and I'll tell you what, I really appreciate that, and again, I know our patients will appreciate it, and I didn't think that the exercise balls were part of BAMLAN therapy, but I just wanted to be sure, so I'm glad you clarified that. Anything you wanted to add to that, Hawk?
Yeah, I think it's important to note, you know, the initial studies that came out looked very optimistic for keeping people out of the hospital. The studies that were looking at people who were using it in the hospital were stopped because there wasn't any efficacy. So it's important to note that this isn't a panacea. This doesn't mean you can go out and get COVID-19. You can go out and be irresponsible. But it also doesn't mean that just because you have COVID-19, you will qualify. There are criteria. We should understand that the NIH guidelines for treatment still do not recommend for or against this medication because of the lack of full data. The same thing with the Infectious Disease Society of America, the IDSA. They don't recommend routine use for this medication as well. Just as she had described, there are specific criteria that we are using to screen patients for. In addition, as she said, it is an outpatient medication, so we are, it does take time in the outpatient infusion center. Right now, one of the big holdups here at the health system is the amount of space and infusion time that we have, but we are looking to expand that at a couple different sites here within the health system as well. So we do have active screening process to see if you meet that criteria, and the most important part about this is getting it early. If you've had disease for 10 days, it's probably not going to help you much. You are moving out of that viral phase of the infection and into that inflammatory phase, but certainly within the first 7 days of symptom onset is probably when it's going to be the most beneficial. But studies are still ongoing. We are still actively doing the study here with Dr. Castro for this medication as well. And so even if you may not qualify through this EUA that we are using, you may still qualify for the Active 2 trial as well. So there are studies ongoing to look at the full efficacy, but just want people to understand that it is still under EUA. You still have to meet certain criteria to be enrolled to get this medication.
And part of the criteria also based upon the limited number of doses we have.
Correct.
As that ramps up and we get more data, I think those criteria are likely to expand.
Oh, absolutely. Yes, but we just, it's very early, and we now have 2. We have the Regeneron product and the Eli Lilly product, so that helps with our supply as well. There is nothing that says one is better than the other at this point in time, so we are using both of those.
And can a patient elect to get one or the other, or is it just whatever we have, whatever's up next?
I think it's just probably whatever is up next, but we can ask Shannon.
Shannon, how do we decide between which product somebody gets?
Yeah, we're just giving both of them. We've given a couple of each of them, but yeah, I think we've got 200 and some vials total currently.
That's awesome. That's more than I knew, so that's great.
Yeah, and so, there was, we didn't do anything Thursday, Friday, Saturday, Sunday. We don't infuse on the weekends, but we are filling up slots now. And again, there is actually an active screening process, so we know who is testing positive. We do understand right now it's only for the health system patients, but we are looking to expand that once we have these other infusion places that are able to give the infusions as well. So there is an active screening process that we're looking at patients who are positive and then contacting them and seeing if they qualify.
All right. Well, Jill, let's turn and see if there's questions from either reporters again about this or from our listeners.
Okay, I'll let reporters go first. Anybody have a follow-up question? Then I'm going to go with Jillian's question because I like her name.
Jillian, of course you do, Jill.
She wants to know, is this a one-time infusion or multiple?
Yeah, I believe it is a one-time infusion. I don't think there's any data that says you get more than once, because what's happening is, and Hawk, let's talk a little bit about how it came about. These antibodies were really ones that were taken from patients who'd had SARS-CoV-2 and had a very successful recovery, and then in the lab, those antibodies can be made.
Yeah, absolutely. These are engineered, so it's not really a blood product, but it is engineered in the lab. These were very highly efficacious neutralizing antibodies to the virus, and I think they were originally, at least I know for the Regeneron, I believe they were originally identified in patients. So these are identified and known that they have high neutralizing activity against the virus. They are engineered in the lab, and so that is why we should get more supplies of these as time moves on as well.
Yeah, I think it's really exciting because I think this is a great example of science being translated from the bench right to the bedside in a very rapid fashion. And I think as we sit back, how are we going to find our way out of this crisis and out of this pandemic? The answer really is our own personal responsibilities and science. And one of the things that's still incongruous to me, and I think that Paul did a great job of talking about this, is the people who don't want to wear the mask, even those there's good science, but they may want to take monoclonal antibody therapy, or they want to have hospitalizations and get the treatment we can give here, or vaccination, and that's all got science behind it.
Right.
So if you don't want to wear the mask because you don't want to believe the science, why is it you want to do the other stuff?
Yeah.
It's a little confusing, and I think the reality is that science will help us find the way out of this. As well, science is helping us cure cancer. Science is helping us treat heart attacks. Science has really advanced the treatment of strokes. Science has remarkably improved the outcomes in cystic fibrosis, the disease I treat. Science saves lives, and we need to pay attention to the science.
Does this drug require any kind of special refrigeration like the vaccine does?
Oh, great question.
Storage.
How do you handle this, Shannon? How do you handle the drug?
Yeah, it's much easier than it sounds like the vaccine's going to be. So yeah, we just have it in our fridge with our other medications. The pharmacist sits it out for about 15 minutes, and it only takes the tech about 5 minutes to mix it. So it's a pretty simple process.
All right. Well, that's a lot better than some of the vaccines. So it doesn't have to be at minus 80 for like an Arctic icicle. It's not like that.
No.
Awesome.
Ann wants to know if someone has their positive test outside of the KU system, how can they access monoclonal antibody therapy?
Oh, that's a great question. Thoughts?
Well, if you are a patient of the health system, we do have a number that you can call. I don't have that. Maybe Shannon does. And if you can have that result and maybe talk with somebody on that number. But again, right now we are only offering to health system patients just because of initially we had supply issues. Currently we do have the infusion space and the time it takes to infuse, but we are looking to expand that eventually. And I don't think it'll be too long before we do expand that access. But right now that is the way to go about that.
Shannon, anything you want to add to that?
Yeah, that's correct. So if you have a positive test outside the health system and are currently health system patient, you can get your primary care physician. We need to have that positive test result to view that. But if you can get to your primary care physician, they can get in touch with the swab clinic or give you the number to call, which I'm not definite, so I don't want to give the wrong number. But call and they can get you vetted through that process.
Okay. And as we get more doses, I think it'll be like other things we can offer to people outside of our system. But I think right now we started off with our patients we thought were going to be most vulnerable inside the health system, in which there are approximately a very large number. And I think other hospitals are really the same way. Just to be clear, every hospital is getting these drugs. It's not just KU. So, Luke's has it, Advent has it, HCA has it, everybody's got it, North Kansas City, Liberty.
But to your point too, there is a emerging infections network. It's a listserv, a thread basically, and there are a lot of hospitals who aren't even doing this because of the systems that are needed and the time it takes.
Right. So, it is a specialized infusion, right? And you have to have a specialized treatment area. You can't put these patients next to a non-COVID patient. And so you do have to have a lot of planning around it.
Yeah, absolutely. Yep. So there are hospitals who don't even want to deal with it because of those issues. So I think we are, I don't want to say unique, but we are in a privileged few who are able to do this. We all are also working very closely with our cancer center to get those people who meet the criteria and those high-risk patients to get it as well.
Jill?
Angela wants to know, what is the criteria
Let's go through
currently?
It. All right. Which of you guys want to go through those criteria with us?
We can let her start.
Shannon?
All right. Most of the patients we are seeing are over 65. So over 65 is a general criteria, but then also comorbidities such as, diabetes, kidney disease, any sort of immunocompromised patient, whether that be from chemo, cancer, rheumatoid arthritis, all sorts of different things. But also if you're under that age of 65, asthma, obesity, other things will also qualify to get that treatment. I believe we've done a 23-year-old and also someone else in their 20s as well. So definitely there's criteria, but a lot of people could still qualify.
And Hawk, if you've had a transplant, would you be able to get this drug?
Yeah, absolutely. So going back to her question, obviously the biggest issue is going to be 65 and older. The next one is the BMI of 35 or more, so morbid obesity. And, Shannon talked about those other comorbidities. We also can look at if you're age 55 or under with other comorbidities. One of those things that you mentioned is transplant. So if you've had a solid organ transplant or a hematologic stem cell transplant, if you are unable or you have B cell or T cell deficiencies and you are unable to make antibodies, this is potentially therapeutic. Now, we don't know for sure in those populations because it hasn't been studied because there are so few of those patients compared to the general population. But we assume and theoretically believe that you should have some benefit from this drug. Say if you don't have a B cell or T cell immunity because you had a recent transplant or you're on chemotherapy. Now, we don't know the full implications, especially if you don't have a T cell response, but we would hope and assume that those patients who are severely immunosuppressed will benefit from this antibody.
There are some patients who don't make antibodies to diseases or may not make antibodies when they get a pneumococcal vaccine or MMR, any of those. Would that be somebody we would think about giving bamlanivimab to?
They would be in criteria for humoral immunity or immune deficiency. Yep.
Yeah, so I think there are a lot of patients out there, and the only way to know that is to go through the screening process. So if you think you've got it, or if you have COVID-19, I think I don't think there's any problem with trying to see if you meet the screening criteria, Absolutely. And I would encourage you to do that.
Janet wants to know, is there a way to contact the patients so we know how they're doing? I would suspect they're being followed. Could we talk about that a little bit?
Yeah, I think it's pretty early in our infusion, so we can't draw too many conclusions, and we give us a month or 6 weeks and we'll have better information, Hawk.
Yeah, and again, they are probably going to be in contact with their primary care physicians as well. But it is very early. Like you said, it's only been 15 patients. Despite, we tried to screen a lot of people yesterday, and none of them really met the criteria as well. So, again, with that active screening, hopefully we'll get more patients with more access and more sites to infuse. Hopefully we'll get more patients.
And also to say, just to draw an important distinction here with bamlanivimab, there is an active study going on that is asking each of these questions about how are you doing, what's your response like, and they use symptom scoring systems. That's much better than our calling and just asking somebody that question. Yeah. So really what you want to do is look and see what the scientific papers are that are being published. You can actually go look at those. The New England Journal is open access for its COVID-19 data. And so as are many other journals. And although it's kind of written in science speak, if you look at the abstract or the conclusion, the summaries, you can get quite a bit of information out of that. So if you're interested, I do think you can go find how it's going early on with some of these studies. And I would turn actually to the scientific side of this to say, let's see how patients are doing in those published data reports, because that will be controlled questionings, controlled information, meaning that it's taken a really good eye at that. I've only known a few folks who got it, they felt better, but I don't know what that means in a broad study. So, okay.
Okay, so what percentage of patients have a good outcome once they are ventilated?
Oh, that's a great question. How many patients come off the ventilator, Hawk?
Yeah.
And, it wasn't great early on in the crisis. It was only about a third, but I think about more than half, more than about 60 or 65% are coming off now.
Yeah, I think it's getting better. I don't have those full data either. I don't know, but I do believe that it is a lot better now. Now, number one, we are trying to ventilate less patients. We don't want to put them on the ventilator if we don't have to. But two, even if you are getting on, I think our percentage of people who are doing better and come off the ventilator is better than it was, say, in March and April, but I don't have those full numbers.
And I would also urge you to remember that even if you come off a ventilator, you may not have a normal lung. Yeah. One of the problems of SARS-CoV-2 and COVID-19 is that we're talking a lot about whether you live or die. But there's also a question of how you live. Because even in those patients who aren't hospitalized, they may have long-term damage to their heart or to their lungs. And it can be, they may never recover or may take months, even years to recover. So I would urge you not to just think about this disease in terms of life or death, although that's how we're always talking about it, in fairness to you. But I would also remember there's injury, and that injury can be very significant and very severe. So even if we get you off the ventilator, the question is going to be, what is your life going to be like? And the answer to the question is, wear a mask, right? Keep your distance, wash your hands, shelter at home whenever you can, because you will stay safer like that. And real meaningful hope that is preventive is right on our doorstep, because the vaccination is right. I mean, it's right around the corner. So all the sacrifices you've made to stay healthy will have been worth it, because once you get vaccinated, your odds of getting this disease or getting sick from it will drop dramatically. And I think we just can't get away from that message. There's injury, there's death, but really there's hope, and we have to focus on that.
Yeah, and I think even much more than the ventilator, if you go to the ICU, if you are critically ill and go to the ICU, you have a higher chance of having mortality at 60 days, say, than somebody who's just in the hospital for COVID-19 on one of those regular medical floors. So even just going to the ICU can portend a higher chance of mortality at 60 days as well. So it's not just the ventilated patients, but it's because of those things that you talked about, because of the lung damage that you're dealing with, because of other body effects that we're dealing with when you have critical illness and are in the ICU.
Rebecca and others want to know, does a patient here mean you have a primary care physician or you have established care with an expert? They want to know, when you say our patients get it first.
You bet. So I think that either one will work.
Yeah.
You don't have to have be primary care here. Your primary care can be outside of here. But if you're one of the health system patients, you're a health system patient, so we can do this.
Yeah.
And again, we think that'll expand more generally as soon as we get enough doses in. But for now, it's really a health system patient, and so I do a lot of that. Right, I'm in a specialty clinic, and their primary care patient, their physician may be out in western Kansas because that's where they live. But they're one of our patients who have cystic fibrosis, as an example, and someone like that will say, okay, no, you've got underlying lung disease, let's get you in. So you're our patient.
Yeah, and the other reason is too, we have ready access to some of those criteria that Shannon has been talking about. Age, BMI, things of that nature. So it helps in that screening process as well, because time is of the essence. You really want to get in within 7 days of your symptom onset, probably to have maximal benefit. So that is one of the reasons as well.
Luis wants to know, if I get sick, can I come to your hospital? I live in Missouri. Do I need a doctor's special permission?
You can come to KU. You do not need doctor's special permission to come into KU Hospital because you live in Missouri. I live in Missouri. I come to KU Hospital. So I think we actually have about 35 to 40% of our patients come from the Missouri side of the state line in general. And so we take care of a lot of folks from Missouri. That is not a concern at all. Now, the one thing you have to think about is if you have Missouri Medicaid and you're in the managed care side of Missouri Medicaid, that can be harder, because Missouri Medicaid the managed Missouri Medicaid program will not allow you to go seek care outside of Missouri. So that's just something to think about, but otherwise there's not an issue.
And in the context of the monoclonal antibody therapies, again, this is not for patients who are hospitalized. This is for patients who are in the early stages of disease who have a higher risk of hospitalization. So coming to the hospital to get this would not be good. We do not give it to hospitalized patients. It's not EUA approved for that. So.
And I think you addressed this, but people may be coming late. They want to know if the monoclonal antibody can be used prophylactically to bridge until we get a vaccine.
No, that is not part of the therapy right now. No. That has been talked about, but that has not been studied. That is not something that we're offering, and we simply don't have enough doses to do that anyway. So if you think about it, there are 650, or yesterday there were 750 new diagnoses of COVID-19 just in the metropolitan area alone. We have 200 doses right now. We don't even know when our next shipment's going to come. So we would rapidly overwhelm that. So there's no way we could do that.
One person wants to know if hospital and health system employees get preferential treatment for the monoclonal antibodies.
They don't, actually. And I can say that with great conviction, because the truth is you still have to meet the criteria. If you meet the criteria, you can get it. If you don't meet the criteria, you're not going to get it. We don't look at your place of employment to determine those criteria. It's strictly off of health criteria.
And if they work here, to follow up on that, but they have their health care somewhere else, they still need to be an established.
Yeah, we're looking at established patients of our health system.
Okay, and then Loretta wants to know, are all the hospitals in our area full of COVID? Where do I go for treatment if I need help?
So the hospitals are all full of COVID. There's no question about that, but we're still taking care of all sorts of patients. So I think yesterday we had 725 patients, and 160 of them were here because of COVID. Well, that just tells you that 560 did not have COVID, right?
Yep.
And so by far the overwhelming majority don't. The struggle for all the hospitals around our area is that we're all getting hit with a large group of patients for whom no one plans for pandemics, and you can't hold 200 beds in your hospital open at any time because of a pandemic, because there's no way to economically do that. And so there are some patients who have been displaced. But what we also know is that there has been a pandemic effect. It's fascinating. I was looking at an article today in the Washington Post. It talked about how healthcare costs nationally, in the midst of the worst pandemic since 1918, are down. Because people aren't going to get care. And they're afraid to go out. Okay, I get it. They're afraid to go to hospitals, where the safest place you can possibly go. Or they are, or maybe they may not have their job. Maybe they don't have insurance.
Right.
And so there may be really strong economic reasons. And so we know that people are presenting later with their cancers. Women are not getting mammograms. We heard that from one of our breast cancer surgeons. And when you think about that, it means you're not getting a mammogram, so you don't go until you find the lump yourself, and by that time it's a lot bigger. So, gosh, we know that people are presenting with cancer later. We know that people are presenting with more advanced heart disease than they normally do, more advanced lung disease than they normally would. And I think it's all because of the things we said. People are afraid to go out into hospitals because they're afraid of COVID. They don't have their job. They've lost their health insurance, or they're just scared in general. So the reality is that healthcare costs in the United States, in the worst pandemic since 1918, healthcare costs are actually down across the country. That is a remarkable story, I think.
All right, we have time for one more question, but before we do, my rockin' team in the control.
I see it, have given us the primary, if you need a primary care physician, you want to get one at the University of Kansas Health System, there it is, 588-1227. We can get you set up with one of our great primary care docs.
All right, and last question is going to go to Lori, and she wants to know if you guys would comment on the change in quarantine days by the CDC.
We need to.
What
I meant to get that earlier. I meant to get that too earlier. Okay, Hawkeye, defend it. Because I'm not sure I like it, so you have to defend it.
I think everybody is uneasy about it. We said we wanted to see the data. What their data is based on, and this is for just going through quarantine of 7 days or 10 days or 14 days, going through quarantine and getting a PCR test at 7 days, 10 days, or 14 days, or going through quarantine and getting an antigen test at 7, 10, and 14 days. And what they showed in those tables, if you look on the CDC, is they are basing it off the risk of transmission to other people at those certain time points if you are doing that testing. Again, PCR or antigen testing. And so they are basing it off of what is the risk for one of the tests for testing at 10 days, I believe it was like 1.4% you have a risk of transmission if you get the PCR test done. It's around 1 to 5% if you get the antigen test, and I'm a little bit off on those numbers, but just understand it's based off the risk of the potential transmission of the disease if you have it, if you get out of quarantine at any one of those dates. Now, I think that's great. That's a good mathematical model. And certainly we know 1% is pretty small, 5% is small. When you have 10 or 20 people or 10 or 20 infections, that's a very small percentage of infections. But when you have 1,000, 10,000, 100,000 infections, and you have a 5% chance of spreading it, risk of spreading it at the end of that quarantine, that's pretty dangerous. But they based it on that risk of transmission of disease at that time point, whether it's 7 or 10 days. So what they are saying now is, even at 5 days of quarantine, if you get an antigen test or a PCR test, you can get out of quarantine if it's a negative test. Now, be clear, also look at your state health departments, because KDHE is only using PCR tests. They are not using antigen tests. I don't know what Missouri is using. So just understand that as well. So there are the CDC recommendations and then the state recommendations. But I think it's potentially dangerous. You can go back to the CDC and say, well, it is a small percentage, but certainly we understand that you can have those incubation periods up to 14 days.
So what do you really think?
I think it's
I think it's edgy.
it can be dangerous. Now, if everybody were, and I'm sure most of our audience is probably doing this, but if you were doing the other pillars that we've talked about, and that is not gathering in large groups, wearing your mask, physical distancing, doing the hand hygiene, I think that that will definitely push that percent of risk of transmission down as much as possible. But we understand, and what we have seen these past 9 months, people aren't necessarily doing that. So I think it is a little bit risky.
Yeah, what's the World Health Organization say?
I haven't seen what the World Health Organization
Yes,
said
I haven't
yet.
either, I don't remember. Okay, Shannon, final thoughts from today.
I would just encourage everybody, if you're having symptoms, to get tested quickly for this therapy. There is a short timeline, so getting tested and getting that result and getting them to be seen is a short timeline.
It's because we say you need to be within 7 days of symptom onset, and so you don't waste your time thinking you got a cold, you got allergies. Go get tested. By the way, getting tested early keeps everybody safe, because that way, if you know you're positive, you can go ahead and quarantine yourself, and you can call and see if you can get that therapy. So thank you very much, Shannon, for helping us set that thing up. You guys have done an awesome job, and I know the patients are going to be super happy about that. You guys have led the way, so thank you. Hawk?
Again, I think this is one of the other things, the monoclonal antibody, one of the other things that are hopefully putting us on the straightaway to round that turn. I think the next one is the vaccines. We know next week will be a huge vaccine week. We know much more information will come about in the coming few days or week when the vaccines will be available. And most importantly, again, it's okay to be reluctant if you're going to use that reluctance to really do the due diligence and read the data, read the publications to understand, because that's what all the healthcare providers are going to do. They want to see that, but we know that the NIH and the FDA, all of that stuff is transparent. So they do and are going to be approving these or EUA category based on the safety and efficacy.
Yeah, I saw one article that said Pfizer will be ready to ship to the day after the EUA is issued.
Yeah.
So we'll see how long it is before that EUA comes. Hey, tomorrow we know this is the holiday season. A lot of you want to do a little shopping. We know local merchants need you to shop. We're going to hear from some of our local merchants on creative ways they are working to keep everyone safe and stay open. There you go. There's a list of them up there. I think that's great. We'll also be hearing from the KCK Chamber of Commerce, and one of our nurses who cares for COVID-19 patients is going to share a gripping story. Gosh darn it, every day we say the same thing, don't we? Wear a mask, keep your distance, wash your hands, stay at home if you're sick. Don't go out and congregate in large groups. And you know why we say it every day? Because it works. The same science that's brought you masks and keeping all the healthcare workers healthy inside of hospitals because we follow infection control, that science is also the science that's helping give monoclonal antibodies and getting to vaccination. Believe the science. Listen to the science, because it's not going to lead you we're not going to lead you astray about that. One of the things we've tried to do in this program is to not flapjack. We don't flap our arms. We don't jack with the truth. We're going to tell you what we know. We're going to tell you what we don't know. And we're going to tell you what we think might be a little edgy and what we're pretty comfortable with. Because we know that from your standpoint, getting through this crisis safely takes a couple of things. It takes dedication and it takes devotion. Dedication to the principles of infection control, and devotion to those you love and care for, because by being dedicated, you are devoted. We'll see you tomorrow.
If you're aiming at what keeps your family safe from coronavirus, think of each of the things on the list here as a slice of Swiss cheese with the holes in slightly different spots. So physical distancing, one intervention, one barrier, but not 100% perfect. Mask wearing, another intervention, another barrier, but not 100% perfect. Hand hygiene, right? Frequent hand washing, another intervention. And then rapid testing in symptomatic patients or those who are exposed. Each of these things matters. We know that if you do them, you can keep yourself safe.